class from yesterday in YouTube to give them my Monday class the recording, and I saw that my exam one review had 268 hits on it. So for those of you that watched it, thank you. Hopefully it helped, and hopefully the other reviews helped as well. But congratulations to everybody. If you scored lower than a 78, I've sent you an email over the weekend to try and please schedule a time with me to review the concepts that you struggle with on the exam. For anybody that has an overall KGA below a 78, I sent you a mid-mod assessment, and that means that if you could schedule a time to meet with me, so just we could talk about a plan going forward for going into the home stretch here. Okay, so if any of you fall into those two categories, you received emails from me over the weekend, and I've already heard from a lot of you, and have either met already or have something scheduled this week. Okay, so if you could be mindful of that, I would appreciate that.
Professor, the KGA that's listed, is that with the homework
Yep.
included?
Nope. That was part of that was part of my announcement, that when I posted the grades, I also turned the homework grades off so that nobody would be confused.
Okay.
So that overall grade now represents it's just straight up KGA. So those would be 2 exams and 4 quizzes.
Professor Kershaw.
Pardon me?
I'm trying to see, can you hear me? I can't get my computer to go back to you, but is there any way you guys can change some of the review times? Because my class can only go to 1, and that's Professor Kershaw's on Sunday, because we're in class on Monday or whatever day you do it, and we're in class when Professor Ford also does it.
Okay.
So we're not able to go to 2 of the 3. So I like to go to all 3. When I do the recording, it gives me information. So I'm better learning in person with the teacher than watching a review personally.
Is there a particular, I know you're from Port St. Lucie, I believe, yes. Is there a particular, I can be flexible with mine. Is there a particular day, time that works better for Port St. Lucie?
Because we all have different classes on different days. There's only like 4 or 5 of us that are in the same class, except for like on Friday.
Okay.
All of us are in Friday class, so we don't get out of school until I think 2:30, 3 o'clock or something like that.
2:40.
Good morning. Laura, if you want to just send me some suggestions. We had overall, between the 3 of us in our live reviews, we had excellent attendance for exam 2. Live.
Yeah, the only one we can go to the Fortis St. Lucie people, most of them can go to, is the Sunday with Professor Kershaw.
All right.
Because we're in class with our
And
pediatrics.
remember though, that we're trying to accommodate.
I know you're trying to accommodate a lot of different
campuses.
Schools. Yeah,
12 different campuses. So if Port St. Lucie, Laura, how about this? Why don't you get together with your teammates in Port St. Lucie and come up with maybe a day and time that would work better for you, and send that to me, and I'll see what we can do.
All right, thank you so much. I appreciate that.
You're welcome. I'll check with my teammates and see what we can do. I'm not opposed either to doing a second review myself at all, if it helps. So anyway, welcome. We have everybody here now. Welcome to week 8. We got a lot of ground to cover today. We're going to cover last week's content and this week's content. I do have a week 7/8 Kahoot. If we have time, we'll go through that. If not, I will send it. I will send the link to it with the recording from today. Okay. I really want to cover the content since we have a lot of it. But I'm okay with either doing Kahoot as a class, but I'm also okay with you guys doing Kahoots on your own. Right? At least we have one, right?
Okay.
What else did I want to mention before we do the quiz? Somebody probably needs to mute. That's a lot of background noise. Before I talk about the HESI prep, let's just do the quiz, because the quiz is set up in your grade book. It is open. Okay, I tightened up the setup. Okay, so a couple things are new with this quiz. There is a 15-minute limit, so don't start it quite yet. There's a 15-minute limit. We can't be doing half-hour quizzes. It just cuts too far into the class time, and I want to review content. So it's a 15-minute limit, and there's an access code today. And the access code is my last name, Marvel. Okay, so let's start with that. Let's start with quiz 5. You may need to refresh because it became unlocked right at class time at 1:00. All right, so
Is it a
everybody,
capital M?
capital Marvel. That's your access code. Once you start it, it's a 15-minute time limit. Don't forget to hit submit, and everybody needs to stay on camera for the quiz. Okay? Take your time, but do know there's a time limit on this. Okay? So go ahead and get started. I'm going to mute myself. If you have any questions, just put it in the chat. How's that?
Can you say the code again?
It's my last name, Brianna, Marvel, with a capital M. Everybody done? Okay. How'd you do? Charmaine, you're always shaking your head like that.
I just want to say I surprised myself.
In a good way?
Honestly and truly, yeah.
All right. Congratulations. That's awesome. All right, if everybody could come back on camera and we'll review the quiz. During your quiz, I sent a few reminder messages in the chat to students that I need for you to reach out to me if we need to meet. So it was a private message. It didn't go
Oh,
to
I forgot to
everybody.
sign
But
in.
if you receive something from me in the chat, just try and follow up. Josephine and Promise, if you could come back on camera, that'd be great. Christina, I can't see you. Danya, I can only see your forehead. There you are. Okay. All right.
Okay.
Promise, Josephine, you there? There's Josephine. Okay. Okay, awesome. All right. Let's go ahead and review the quiz. Can everybody see my screen? Yes? All right. All right. Infection control and prevention. This is what this question is about. Right. So which of the following are effective parts of infection control to reduce the incidence of healthcare associated infections? What are the right answers? Agreed? C is really not applicable, but A, B, and D are. Any questions about that? Okay. Number 2. Another infection control question. In addition to observing standard precautions for the client with primary TB, what other observations need to be followed? What's primary to TB?
Airborne precaution.
Airborne, right? We should know that. What I heard from a lot of my students yesterday is a lot of this has been covered, a lot of this content's been covered in Med-Surg too. And a lot of these questions were repeat for them. So that was good to hear as well. Okay, another infection control question. Airborne precautions requires which of the following precautions?
B,
B,
D,
We definitely know B,
and C.
C,
and D.
and D. That came right from your notes, right?
Mhm.
And if anybody wants to jump in and clarify or ask a question, please do. I'm just going through these. Which of the following medical asepsis principles are sufficient for in-the-home contact precautions?
A,
Always
B,
A,
B,
B
B,
C.
and C.
C. Again, from your notes, right?
Mhm.
Okay. Sarah, the nurse, knows that a client needs to understand that the HIV test cannot identify infections that may have been acquired within the previous 12 weeks or 3 months before the test. Which of the following statements by the client indicates that further teaching is needed? So what are we looking for? What kind of question is this? It's a negatively framed question, right? What indicates further teaching is needed?
Is it C?
Right. All the other answers are actually correct information, right? So appearance of HIV antibody can take up to 12 weeks. Therefore, the original test could be negative but positive within 3 months, right?
Mm.
B is correct as well. It's a correct statement. And D is a correct statement. So C indicates they need further education, further teaching about this test, right?
Yes.
Okay. Okay, we're going to talk about disasters, bioterrorism and disaster in a little bit here. So we know that natural disasters can be devastating to the community. The nurse is providing yearly education. Okay, so she's doing an in-service for the community. Which statement by one of the community members indicates, again, that further teaching is required? So a negatively framed question, right? This was in your notes.
Letter C.
Everybody gets
C.
C?
I didn't. I did B, but I knew it was C. I just read the question wrong.
Charmaine?
Yeah.
Charmaine. I won't scold you in front of the group, but Charmaine. So all the other answers are correct. Okay. Okay. What is the significant difference between smallpox and chickenpox?
The soles of the feet.
The sole is not cannot be seen on the palms of the for the
Exactly.
chicken pox.
Exactly. So the correct answer is B. Anybody have any questions about that one? Okay, this is a bioterrorism question. Which actions by the nurse accurately indicates understanding of proper management for a patient client that's been exposed to a toxic chemical spill? Definitely A, B,
B,
C,
C, and D.
D. Everything applies. Okay. So we'll talk about this when we get to home health and case management, a little bit more in depth, but the sharing of information from one healthcare setting or provider to another is critical, right? For community-based nursing care. Remember, community-based, we're based in the community, right? We're caring for individuals in the community, especially as clients are making the transition between hospital and home. And so what's an example of this?
C.
Letter C.
C.
That right. So,
I mean, the question kind of gives you the answer, right? The
yeah.
B has nothing to do with it. A has nothing to do. B has nothing to do. Yeah, we might be doing D, but
Yeah,
the
I thought
the
B would be, yeah.
right. But before we even think about the pharmacy issue, there has to be communication between wherever if they're going home and they're going to need home health care, whatever facility they're coming from, there has to be communication. We need to know what the plan is.
Right.
Okay. And then the last question, we'll talk about the difference. These are in your notes as well. We'll talk about the difference between physical neglect and emotional neglect. But we do know that physical neglect refers to failure to provide food, clothing, shelter, hygiene, or
Medical
Medical
care.
care.
medical care. Right? Okay. Any questions about your quiz?
No.
All right, let's jump to content. Okay. All right, so let's jump back to last week. Okay. We always think about infection control, prevention of spread, especially when we work in the hospital setting. But infectious disease prevention and control plays a big part in community nursing as well. All right, think of all the things that can be acquired in the hospital setting. Okay. One of the things that I want you to learn about is called the epidemiological triangle. Okay. Triangle has three parts to it. Okay. It has an agent, a host, and the environment. Okay. What's the agent?
The microbe that's causing the disease.
Exactly. Is it a bacterial issue, viral issue, chemical issue? The agent, you have to have an agent. Okay. Is it the flu? Is it pneumonia? Is it COVID? Is it exposure to anthrax? There has to be something that we're starting with. Okay. Then that agent will affect the host. Who is the host? Us. Right? There has to be a host to infect. Okay. I'll give some examples in a minute. The third part of this is the environment. And that's what this first paragraph refers to. In the environment, things can play a factor in how sick you get or how not sick you get. Okay, so it can be physical issues in the environment, biological, social, cultural. These all play a factor. All right, so environmental factors can facilitate the transmission of an infectious agent. Okay, so let's do some examples. I always like to do COVID because I was in the schools when COVID hit. Okay, the agent is COVID. Okay, let's do a couple of different environments with COVID. Let's do a nursing home. Okay, full of elderly people. Okay, so the agent is COVID, the host is your elderly population, and the environment is a nursing home. We found out from COVID that this group of people was much more susceptible to get sicker. Did we not? Let's change that environment. Let's keep the agent COVID. The host, let's change the host to an elementary school. Kids. Okay, and the environment is a school. That group, the host group, was much less likely to get sick from COVID than the elderly. Does that make sense? Host. The host is anybody. Let's talk about the host. Let's say you have a host that is not healthy, right? Maybe has a low immune system from whatever, has comorbidities. That host is going to be much more at risk to get sicker from whatever that agent is. Does that make sense?
Yeah.
Am I explaining that clearly, or am I confusing you? So you must have an agent, which is the bacteria, the virus, whatever, that infects a host. Host can be anybody. How healthy is that host? How unhealthy is that host? And then what environments are contributing to whether there's going to be minimal impact of that agent, or there's going to be a bigger impact of that agent. That is the basic premise for the epidemiological triangle. And if you think about it, there's a gazillion different scenarios that can play out. Right? Think about the flu. Think about how at risk elderly are with the flu. Do they, I mean, think of all the deaths we have in hospitals over the course of a winter for elderly people. However, let's say that elderly population is fairly healthy and they get the flu shot. Does that make them less at risk for getting severely sick from the flu or pneumonia?
Yes.
Yeah. Right? But I always use COVID because it's a perfect, we learned so much. We learned early on that the elderly was very vulnerable. Being enclosed in facilities was very vulnerable to that COVID, right? But you go to the schools where I was, and it wasn't that big of a deal. You know, these are healthy, resilient for the most part kids. We definitely had to keep an eye out for the kids that were immunocompromised. Maybe they were going through chemo or have a history of cancer, right? Questions about that? That's the simplest way I can explain it. Okay? We need to know the difference between an epidemic and a endemic. So endemic are infectious communicable diseases that won't go away. They're going to be around forever. Flu, COVID. The flu right now is endemic. Now, let's say in my community, we all of a sudden have this huge jump in flu cases. They're in excess of what we were expecting. Then the flu then for this winter season becomes an epidemic, right? But it's always going to be endemic. COVID's always going to be there. COVID's endemic, right? An endemic level of a disease, it just provides a baseline. We're establishing it as a public health problem. COVID's a public health problem. Flu is a public health problem. Pneumonia is a public health problem, right? We move that back into the epidemic period or epidemic level. If we have an outbreak, we have a huge increase in excess of cases. That's a simple difference. Endemic, going to be around forever. Okay? We talked about contact precautions. This was one of your quiz questions. The only thing I want you to know about requirements for disease reporting is there is a federal database of reportable diseases. Okay, that then gets carried into the state level and then into the local levels. So for example, when I was in the schools, we had from our local health department, we had a manual of reportable diseases. Okay, there's some that are standard federally required. The state then can add to that, and the local health departments can add to that. I apologize, I'm fighting a cold. So where you work, whether you work in a doctor's office or a school or a hospital or an urgent care, there's certain diseases that are mandated to be reported to the CDC. Okay, they update these annually. They may add, they may delete, but I'm thinking back, the most common reportable diseases I reported: pertussis, measles. I mean, we don't report lice. We don't report scabies. We don't report hand, foot, mouth. But we do report hepatitis, HIV. I'm just throwing out some common examples that I was always reporting. Okay. Any kind of STD, any pertussis. I already said pertussis. Think of what other really high risk communicable diseases would be reportable.
Tuberculosis,
Pardon me?
tuberculosis.
Yeah, right. So I simply want you to know that there is a requirement for reporting certain infectious and communicable diseases, and that goes to the CDC.
So what would you report to the federal
You
one?
s- you
Nothing?
start
You would
you
just
start with
straight
your
cut the
local.
state?
Your local moves it up to the state, and your state moves it into the federal. Your responsibility is local,
Okay.
right? So we do have outbreaks. We do have outbreaks of certain infectious diseases, communicable diseases in the community, just like we have them in hospitals. Right? So we call that surveillance and observation. Okay? There is a difference. Observation. When we're observing, we're trying to identify any kind of trends, any kind of patterns, what resources are available or need to be developed so that we can have a rapid response to that. That's what observation is. Okay. When we do surveillance, we're trying to reduce morbidity and mortality. We're trying to control the spread. Okay. We're not focused, surveillance isn't focused on eliminating the community-based infections. We are looking at the big picture. All right. And there's a couple of different kinds of outbreaks, right? They're called patterns of occurrence. They're pretty self-explanatory. If you have a point source outbreak, okay, that's everybody's exposed to the same thing at the same time. My example is you're in a train or you're on a bus or you're on an airplane and there's some kind of exposure, gas, some kind of gas exposure. Everybody's affected at the same time. So everybody's going to get sick right then. Okay. Intermittent is exactly what it sounds, right? You may be exposed over a period of time. That's why it's called intermittent. So I use a restaurant, for example, let's say a batch of lettuce. Okay. They don't realize is bad until it's been served over 3, 4, 5 days. Right? People will get sick at different times. Food poisoning. You're using the same batch of lettuce over 5 days. Does that make sense? So intermittently, people are going to get sick. Mixed outbreak occurs when one person is exposed to a source, and then it's just person to person to person. So a good example of that is the flu. Right? So I exposed myself to my grandson in the middle of last week who was sniffling and snotting and had gross stuff coming out of his nose. And come Saturday, I didn't start feeling unwell. Right? So it's person to person to person to person. And then you have a propagated outbreak. Typically, propagated does not have a common source. It can gradually spread person to person. And a good example of that is like a TB. Okay. So if you're given a scenario like a flu or a gas exposure or a TB exposure, just be able to identify what kind of outbreak that would be. And so with infectious disease and control, we develop community-based programs for teaching, whether it's primary to prevent, secondary to screen, or tertiary to treat. But one of the things we have to do, think of your ADPI. You have to do some kind of a needs assessment. Is this community more at risk for asthma because they live near a transportation hub and the air pollution's poor? I'm just using that as an example. You have to do a needs assessment of what actual education, training, teaching your community needs. And the only thing I want you to know about the needs assessment is that there are 4 stages during that assessment: preactive stage, reactive stage, inactive stage, and interactive stage. Right? That's why I simply want you to know that you have to start with a needs assessment, and there are 4 different stages. Okay? Vaccines. We know that vaccines are one of the most effective methods for preventing and controlling communicable diseases. However, I'm going to go back to my school nurse experience. What do you do with parents who don't want to vaccinate their kids? They have 3 options. They have their personal exemption, which is, sorry, I don't believe in it. I don't want to vaccinate my kids. You have your medical exemption, in which the doctor says, based on their diagnosis of CP, we don't think that these vaccines will be beneficial and make things worse. Or you have your religious exemption. Sorry, our religion prevents us from getting vaccination. Okay, right? We can't be argumentative. We can't be judgmental. We can't force anything. What we can do is teach, right? And educate. And I did this many, many times with many, many parents in a very non-confrontational, non-judgmental way. Okay? They can make their own choice. In the school setting, let's say I had 10%. I did talk to, interesting, a couple of weeks ago. I told this to my group yesterday. I did talk to a couple of my old nurse teammates in the schools, and one of them told me that this year their unvaccinated rate is as high as it's ever been. Very interesting. But one thing we do, one thing you have to be able to talk to parents about is, okay, you're choosing not to vaccinate. So in the schools, here's the plan. If we have an outbreak of pertussis, you're going to be on the short list to call because your kids aren't vaccinated. Therefore, let's come up with a plan. Do you really want your kids in school with this pertussis going on and your kid's not vaccinated? Those are the conversations you have. All right. But we do know they're very effective, but not everybody buys into that. And that's okay.
There's
Okay.
actually a school in Florida that has as
Measles.
many kids non-vaccinated as vaccinated, and they're the ones with the outbreak of measles. So they're
It-
actually closing the school down.
I've read that, Laura. I read that story. Yes. Yes. Well, another big issue we had with vaccinations was the students coming in from other countries that had absolutely no vaccination records. Well, parents couldn't tell us if they were vaccinated or not. So what do? We tried to provide them immunization clinics where they could go and do that if they so choose. But yes, Laura, I read about that story in Florida, right?
Yep.
Yeah.
In South
Yep.
Florida.
Okay. Couple of particular communicable infectious diseases are HIV, hepatitis, TB, and STDs. Okay. First is STDs. Let's talk about that. Bacterial or viral. They can be either bacterial or viral. Okay. If they're bacterial, such as chlamydia, gonorrhea, that can be treated with antibiotics. If they're viral, they can't be treated with antibiotics, right? It becomes it becomes symptom management, right? The one thing I want to mention about, you can read through these. I'm not going to go through everything line by line because we have a lot to cover. I want to mention something about syphilis. Okay. What does it mean when something is transmitted transplacentally? What does that mean?
That it is transmitted through like
Mom to
Inter-
baby. Transplacentally, right?
Oh, placentally, okay.
If that syphilis is not treated during pregnancy, and that infectious disease is transmitted transplacentally, causes major potential problems. for the baby. Stillbirth, blindness, deafness, facial abnormalities, disability. Okay? I want to mention a couple of things about herpes and genital herpes. I've added this in blue. Okay, these were not in your original notes I sent, so I want to go through this part of it. Okay? One of the most important things that needs to happen with somebody with genital herpes, they need to inform their partners of the disease to help prevent transmission. We don't want to use petroleum products. They can potentially cause the virus to spread. And then we need to educate people that have genital herpes that the notion that it's only transmittable when lesions are present is false. Okay? It can be spread through, it's spread during outbreaks. It's viral. It's a chronic lifelong condition. There is no cure. I mean, you can treat with antivirals, but there's no cure. Okay? Hepatitis. Please know the difference between A, B, and C. It's right here for you. Okay, we know that Hep A is fecal oral contact. B is bloodborne. I give you some examples of people who are at high risk for Hep B. C is also bloodborne, but C also is the one that attacks the liver. Okay, Hep B is typically common in correctional facilities, long-term care facilities, close contact. We went through all of this. This is a quiz question about the testing, right? The HIV testing, to repeat it in 3 months. Okay. This is important to know about HIV, right? HIV, if you live near one another, if you live in close quarters with others, such as prisons, let's say you're going to a prison facility. One of the things that needs to be screened for is TB, right? Because we know that TB can be common in correctional facilities. And if somebody is infected with HIV, they're going to be much more at risk. Think back to the epidemiological triangle. The agent is HIV, right? The host has HIV, and the environment is the correctional facility. They're going to be much more at risk to contract anything that's going around that correctional facility, right? TB, we went through that in the quiz question. Okay, let's jump to bioterrorism and disaster management. Okay, we all work in places that have drills, right? Disaster drills, right? Evacuation drills. Okay, in the community, very high risk for any kind of a disaster. There's two kinds of disasters, natural and man-made. Natural, they occur naturally. Earthquake, droughts, hurricanes, communicable disease epidemics. Man-made, we create. Pollution, warfare, fires, water supply contamination, food outbreak, contaminated food. Okay? We are always going to be involved as community nurses in disaster preparedness. Okay? We are expected to be able to participate at any stage of a disaster in the community, whether it's preparedness, whether it's impact stage, whether it's post recovery. Okay. And I always like to bring up this example of this would be a primary intervention when teaching a family how to put together a disaster kit. What's important? What do you want them to have in it? Food for 3 days. Review the kit every 6 months for any expired items, right? Make sure everybody knows where the kit is located. Make sure everybody knows how to turn off supply or utilities. You remember last week, I don't know if anybody was impacted, we had that phone outage.
Yes.
Originally they said it was like AT&T, Verizon, T-Mobile. I wasn't impacted. But think about it. I had kind of a little, not panic attack, but thinking, how prepared am I for something to happen? Like if I didn't have a phone, do we have a plan? Does our family have a plan? If something happens and all of our communications go down, what's the plan? I mean, it's really rather concerning how many people, families are not prepared. Right? How would I get? Do we have a meeting place set up? There's just no plan. So anyway, after that little incident, and even though I wasn't impacted, I realized very quickly how unprepared I was. But one of the jobs of you're going to be doing as a community nurse, if you're working in disaster preparedness, disaster preparation, is educating individuals, families, populations, communities how to be prepared. The national, yes, we have FEMA, your Federal Emergency Management Administration. That's kind of the big response to all disasters. But we also have another agency within FEMA that's called the National Response Framework that I want you to know about, NRF. And they have specific support that they provide. And here it is. I'm just going to highlight it here for you. Okay, so if we're talking about the National Response Framework, transportation, temporary housing, medical resources, search and rescue, and firefighting. Okay. We covered this. This is just more specific than the quiz question. You know, when's water safe to drink? Okay, the answer in the quiz was it can be boiled. Yes, 3 to 5 minutes. I added that. Treated with household bleach. That was another answer that was correct. Treating with household bleach means adding 1 ml, 16 drops. Okay, letting it stand for 30 minutes. Removing
What'd you
hot
say
water
about
heat.
how much for the 6? I thought it was 8 drops per gallon.
16 drops. 1 ml, 16 drops, and let it stand for 30 minutes. It's right here. Right there. And then the other correct answer in the quiz was removing the hot water heaters. Removing hot water, removing water from the hot water heaters in the commode tanks. Okay, so it's in blue because I just put a little bit more specific information in there. We have to realize that when there is a disaster, everybody's in the impact stage. So what's our job? Let's say you're working in a facility. Okay, our job in the impact stage first is to get everybody to safety, right? Before we can start triaging, before we can impact stage, we need to get to a central place for safety and information, right? So whether that's wheeling people out of their rooms, carrying people out of their rooms to a central location that's safe. Okay, everybody's in the impact stage. Has anybody ever been involved in a man-made or natural disaster? No? Okay.
Yes.
Yes. What kind of disaster?
We had a shooting at our club.
Oof.
So, and then we had a fire the next day. So take your choice.
Oof. Wow. The next part here is about exposure to, so we're getting into the bioterrorism here, exposure to a toxic chemical. Okay, this was a quiz question, so we don't need to go through that. But I want you to go through, I want to go through the 3 different potential agents: anthrax, smallpox, sarin. Okay, you have to be able to recognize in a scenario, if a patient is presenting with this, is it more likely an anthrax exposure, a smallpox exposure, sarin exposure? And remember that anthrax is primarily skin, GI, and respiratory. And it's right here in your notes. Smallpox, skin. Okay. And sarin, what I want you to know about sarin is extreme respiratory. Okay, severe respiratory distress. Those are the differences. And when we also can have food illness, food safety. I don't know about you, but when I go to a restaurant or a fast food, I just have that expectation that everybody who prepared my food prepared it correctly, right? Stored the food at correct temperatures, prepared it in the right way, used hand washing, universal precautions, asepsis, right? I make that assumption. But we have food outbreak illnesses. Do we not?
Yes.
We do. Same with water issues, right? We don't, you swim in a lake, you swim in a stream, a river, the ocean, whatever. But I don't typically think about animal or human fecal contamination or contaminated water, right? Or if I live in an industrial community, do I worry about chemicals getting dropped in the water? Chemical waste, or you live near a dump site, right? Cholera, when you hear about major disasters, a lot of times you hear about cholera and giardia, right? Those are infectious GI diseases from contaminated water. And then we have vector-borne illnesses, Lyme disease, ticks, Zika virus, mosquitoes, malaria, mosquitoes, right? So there are vector-borne illnesses that we may be having to deal with as community nurses. Okay? Questions about any of that? We cover pretty thoroughly. I want to focus on home care and case management. Okay, we'll cover a little bit of community resources, but any questions on the concepts from week 7? Okay, let's jump into week 8. So this week, home care, community resources, case management, and care of complex illnesses in the community. I'm not going to spend a lot of time on chronic complex illnesses because these have already been introduced to you in other classes. And I do want you to review it. There are questions on the exam. But everything you need to know about each of these is in your notes here. Okay, I do want to cover a couple of areas about post-op, and we'll do that when we get there. But you have a lot to read on different chronic complex illnesses. Okay. And that's all those readings this week from your med-surg book. Okay. So let's talk about home care. Where is home care delivered?
In the home?
Your client home.
It's in the client's environment, right? The 2 determining factors about home care. It's in the client's environment and it's individualized care. Right? Traditionally in the past, right? Home care was typically thought about for homebound patients. Okay? That's not the case anymore. Think of all the services we provide in the home now that were typically done in the hospital. or typically only done for homebound clients who couldn't go home. I mean, what are we doing in homes now that 5 years ago, 10 years ago, we would have never thought about doing?
Home-based primary care.
Dialysis.
Both your, yep. Wound dressing changes, PICC lines with antibiotics, right? Therapies, physical therapy, occupational therapy. Years ago, this was all done in the hospital setting. We do so much in the home now, so much, right? One of the primary goals for as home health nurses working in the homes, right, is we are trying to move the client towards independence. That's tertiary. So they have something, right? In tertiary, we're helping them manage, helping them treat their condition, right? By providing training and education, maybe teaching the family, right? Maybe helping them understand a new diagnosis. Okay? Our goal is moving them towards independence so that they can take care of themselves at home. Otherwise, then we're looking at an assisted living, right? But home-based care is to try and provide them whatever resources and help and training and education and teach back and whatever they need, right? We want them to be empowered to be able to manage their own, whatever it is, injury, illness, condition, right? We want to help them facilitate self-care or moving towards self-care, right? We want to give them as much autonomy as they can manage, right? Self-esteem, confidence, resilience. Okay. One of the things that's different about doing assessments, think about doing an assessment an assessment of a patient in the hospital versus an assessment in the home. Okay. An assessment in the home, put yourself in the community now. Okay, I'm right here. I'm right in here. Assessment in the home is very different from an assessment in the hospital. In the home, you're having to evaluate several different things, right? In the home, you're you're a guest, right? You need to develop and foster a relationship with that client or the family or the neighbor or whoever is participating in that kind of care, right? So it takes a while. An assessment in the home could also include a safety assessment, a fall risk assessment, a medication assessment, a financial ability to purchase equipment or medication assessment. Okay, so it's a very, very detailed relationship that you're developing. You know, for anybody who's ever worked in home care and had the same client or the same family for a while, it's all about relationship building and trust, right? Versus a client that you may see on the floor for a couple of days and they go home. You don't ever see them again. Right? So home care is much more detailed, much more focused on the client as a whole in their environment. Okay? One of the things that home care also presents as a challenge is there's a lot of people involved. Right? Whether it's the client, their family, maybe oxygen supply company, medical equipment company, health insurance or insurance agencies, a PT, an OT, a speech, a sitter, a dog walker, whatever. Right? There's a lot more people involved in the home care. So one of the things, and this is from years ago, and this is what that Omaha system is. Visiting Nurses Association from decades ago created an Omaha system. And really the primary goal of that is documentation. Everybody can see everything. All of our health charts now, right? Let's say, for example, I'll use me. I belong to Cigna. I have Cigna insurance. So my oncologist can see what my primary care writes for my visit. right? My dermatologist can see all of that. The labs are all figured in, the tests, the testing, the treatments, the radiation I had is all factored in that. Everything is in there. That's what the Omaha system is symbolic of. Does that make sense? And same for home care. Rather than making phone calls and having meetings, we can all see in the same system what's going on with this client. Does that make sense? The other
Mhm.
thing that's very important in home care is Medicare regulations. They direct a lot of what's approved and what can happen in the home. Right? The responsibilities and functions of other health professions in home care are dictated by Medicare regulations. Okay. They're also dictated by professional organizations. What's our scopes of care? What can each of us be doing? Okay. And then the state licensing boards. What are we allowed to do? Scope of care. What can we not do? Okay. Home care is provided in many different ways. It can be direct care in the home. It can be maybe telehealth, right? Following up with your doctor with a telehealth visit, right? It can be on a consulting basis, right? My message is there's lots of different players. Okay. So interdisciplinary collaboration is critical in the home care setting, home health setting. All right. We want to make sure that services aren't being overused or services aren't being underused. And we want to make sure that the client has the availability of all the services and resources available to them. Okay. Let's see. What else? I mentioned this because it's important, because a lot of times this is an issue in the homes. Fall safety assessment, fall risk assessment, right? Environment, you should be looking to make sure environments are well lit. Right? Is there furniture scattered everywhere that they're going to trip over? Are there loose rugs that they're going to walk over and slip? Do they need handrails, guardrails on their bed? Okay, they're going to get up without telling somebody they want to get up and fall. Can they get from the bed to the commode? If they're in a wheelchair, if they're at risk for falling, is there a belt, a waist belt available? It's one of the biggest risks in the home health setting is safety and fall risk. Okay, because most of our home care is provided to our aging population, right? But the goal is to keep them in their home. That's where they want to be, right? So it becomes very complicated and very collaborative. And I don't mean complicated in a negative way, but there's a lot of players. Okay, and everybody has their own different skill set and participation. Okay, community resources as community nurses. I'll speak for myself as a school nurse. I had to have as much knowledge as possible about all the community resources available to my parents and my students. Okay, because certainly almost everybody you act with in the community, in a community-based setting, whether it's in an urgent care, whether it's in a school, whether it's in the home, whether it's in long-term care, are going to need resources, some kind of resources, right? So it's up to us to have a good understanding of what community resources there are. And if we don't know, where can we go get them? Because community nursing is all about helping people stay in their homes, stay in their community, having all the knowledge of what would be helpful. If you think about Meals on Wheels, Red Cross, food banks, clothing banks, pregnancy centers, where to go get tested for STDs, public health department, what do they offer? Right? Domestic violence shelters, churches, what do they offer? Usually a lot. Okay, transportation services. How do we get our elderly in the home back and forth to appointments? Do they have sitter services? The other thing that we have a lot of now in the community is non-English speaking populations. Right? So let's say you're the community nurse, you have a large let's see, Vietnamese population, but you don't speak a lick of Vietnamese, right? But you know that you want to reach out to that community because you're offering health fairs, you're offering vaccination clinics for the kids, you're offering whatever services. You have to go and seek out your team, your players in that community that can help you. Right. So maybe there are trusted community leaders that work with the Vietnamese population that you can tap into. Okay. There may be religious leaders in the Vietnamese population in your community that you could ask for help and disseminate information or speaking at a service or a function that they have. Okay. The other population that we are seeing more and more of is the immigrants. Okay, the non-citizens. Okay, how do we reach out to them to make sure that they know they can come to a community health fair? They can come to a screening fair. They can go to the schools. They can get immunizations. How to reach out to that community? How do we make sure that they understand that their immigration status is not affected, or their immigration status doesn't affect them, doesn't affect their ability to participate in community services? Okay, our world is changing. Our communities look very different. How do we be inclusive to all the populations in our community? Okay, so that's my spiel about community resources. Okay, let's finish off with case management. Case management, what is it? Case management is the coordination of care. You hear titles of case managers all over the place, whether they are in hospitals, whether they're pre-op, whether they're post-op, whether they're discharge planners. Case management is a term you should have already heard of, right? Oh, she works in the case management department. She works with the clients going home after bypass surgery. All right. Do they have the resources they need? Do they have the transportation they need? Do they have their follow-up appointments they need? You know, case managers may work in pre-op, calling patients that are coming in. You know, have you had your blood work done? Have you had your pre-op appointment done? Okay. Case managers function in numerous roles. But what they are is the coordinator of care. And I always say to students, I believe even though we may not have the label of case management, nurses are always case managers, right? We're always managing everything for our clients, are we not? Whether we're working in the home care setting, the hospital setting, right? A couple things about case management. Like home care, individual based. Not all clients can be case managed. Right? Case management is reserved for the clients who have very high risk, lots of needs, lots of comorbidities. Okay. Chronic diseases, high cost chronic diseases. Right? It's labor intensive. It's a lot of work. It's time consuming. It can be very costly. Right? Because we have such an increase, the numbers of clients with complex chronic comorbidity illnesses, it's really spread thin. Nurses' caseloads that are case managers are really high. Okay. So let's think of some examples of who we would case manage. Maybe we would case manage somebody that has diabetes, that's obese, that has chronic asthma. Those are lots of things going on, right? Maybe through their primary care, they have a case manager that helps them look at every part of their illnesses. You know, do they have programs? Do they know about the programs available to them for weight loss? Do they know about management of asthma? Okay. So with case management, as nurses, we're being advocates, we're being care coordinators, we're being referral. We may be doing referrals. Okay. When I say care coordinator, let's say we have, let's say we have a client who's going home after a quadruple bypass. They've had a pretty routine hospitalization. No complications, very active and supportive family. They're not going home alone. They have a family they live with that can cook for them, clean for them, prepare meals for them, get them to appointments, and they're looked after. That client doesn't need to be case managed. But take the same client, had the same surgery, some multiple complications. Okay, maybe they had to go to a rehab facility. They couldn't go home. They don't have anybody they live with at home. Okay, they don't have any transportation. They don't have anybody to cook for them. They don't have anybody to go get their medications. That's the kind of client that would be case managed. It has a lot of needs. Does that make sense?
Mhm.
Like home health, case management, there's a lot of fragmentation of services as well. You might need an OT, you might need a PT, you might need somebody to deliver your medication, you might need Meals on Wheels, you might need sitting services, you might need somebody to come in, cook and clean. Okay, very fragmented. But the case manager that works, let's say, in the home health agency, she's the coordinator of all that care. Okay, so it requires a lot. It requires that we're knowledgeable about community resources, about insurance. How do we make sure that what the case manager is billing for is covered? Is PT covered? What kind of services are covered? Right? The case manager has to have excellent communication skills, right? Excellent documentation skills, be able to do any kind of conflict resolution. Let's say you come, the doctor's ordered a certain medication and the insurance company is saying, sorry, we don't cover it. How do you collaborate with that insurance company to make sure the client's needs are met? How do you prioritize what they need? Okay. I highlighted these words because I want you to understand there is a difference. Let me make sure. Links to multiple providers. Okay, so there's a difference. We communicate in many different ways as nurses, to include case management. All right. We may be collaborating. We may be having to be assertive. We may be having to speak out of cooperation, speak out of compromising. Okay, so if you're given a scenario, be able to identify what kind of communication this is. So collaboration, right? We're trying to work towards solutions. We're trying to collaborate, trying to work towards solutions that satisfy the needs of both parties. Okay, collaborating. We all collaborate. We try to collaborate all the time in good faith, right? Assertiveness. We may have to be assertive, right? We may have to be assertive as we're trying to validate what our clients' needs are to an employer, a healthcare or insurance company, pharmacy, right? We're presenting our needs for our client, right? Or our needs in general. Cooperation. Cooperating is the ability to understand and meet the needs of others. Right? We're cooperating. We're all getting along. We're all cooperating. and compromising, we're trying to find a mutually acceptable outcome for both parties. It may not be the most ideal, but we're all compromising so that the basic needs of each party are met. Right? So I would think that we probably all practice all four of these on any given day a lot. Right? Okay. I'm going to have you review we only have a minute or so left because we didn't take a break and I want to finish early. You can review your care of complex chronic illnesses, but the one thing I wanted to address is delegation. Okay? When you are delegating, there's specific things that need to be communicated to the person you are delegating. When you're delegating to an unlicensed assistive person, they need to know what is to be done specifically, how it is to be done, what do you expect them to report to you that would be a red flag, or at the end of the shift, what do you want them to report off to you? At the end of the shift, or any concerns or red flags they might have during the shift, what specifically do you want them to communicate to you?
If a patient's unstable or a change
Yeah.
in their
Exactly. Well, remember, anytime you delegate, somebody's working under your license. So you better make sure that you have explained to them what your expectations are very specifically, right? I mean, you would never assign a client who's unstable to a UAP, right? You make sure, here's what I need you to do. Here's how to do it. Here's what I expect you to document. Here's what needs to be documented and where. And here's what you need to report to me if any of these particular concerns happen. Okay? Because you will be delegating. Right? I delegated a lot in the schools. We didn't have, or the big district I worked at, we don't have the model of an RN in every school. We were consultants, so we covered 8, 10 schools at a time. But we called them clinic aides in every building in the clinics that were there bell to bell. But we had to delegate to them, giving medication, giving insulin shots or pump, whatever. And there was, in the 21 years I was there were a handful of times that I pulled delegation. It was too unsafe. There were too many mistakes being made. And there was a whole process to go through with the board and all that, but I pulled delegation, right? To protect my own self, right? I mean, tried to teach, tried to demonstrate, tried to do the teach back. Eventually you reach a point where, you're just not getting it. Okay. And then the rest of the document is all your complex chronic illnesses, which I know have been introduced to you in your med surg classes. So hopefully it's a review. I didn't do bad this time. I'm 3 minutes over. So I promise you 10 minutes early, right? So I know we covered a lot. How was it? Too much? Okay.
Okay. I don't think it was.
Everybody okay? Okay.
Yes.
And then next week is our last week of content. That's it. We only have 2 more concepts to cover. So I just want to real quickly, you should be able to complete, I would say 80% of your HESI prep at this point. Okay. And I hope everybody's been working on it because it's going to be a long, painful assignment if you start that next week. Okay. It was intended to be given in week 1, so you could be working on it. And we talked a lot about this. I just haven't talked about it recently. Now, there's a lot of boxes that I'm not going to cover directly in class. It's not going to be in your notes. but the boxes are under a concept. The topics in those boxes are under a concept we've covered. All right, so you're going to be going back to your books. If we haven't covered it specifically, remember the HESI for community is extremely med-surg focused. That's why you see a lot of med-surg stuff in those boxes. But remember what those boxes are. Those are topics that are being asked about in the HESI. I've gone back through the HESI. I have no idea what questions they're asking, but I know the topics they're asking about. And that's what that HESI prep is. That's your blueprint for your HESI. So if you get to, like, I know there's a box that says below the knee amputation. Okay, you're going to have to go back to your med-surg book and get that part filled out. There's a lot I have covered specifically, but there's a lot. It's not that I haven't covered it. It's I haven't covered that part of the concept because it's not part of community. That's the med-surg piece. Okay, so I hope everybody's working on that. It's due at the end of next week, so you still have time to do it. If you haven't started it, get going on it. Okay, this week, the only thing we have is the quiz. The quiz is over. Okay, there's nothing more for community this week. Nothing. Okay, I think we have our next week is going to start getting busy. All right, next week is going to start getting busy with your HESI prep due next week. Then the vulnerable populations due right behind that. That same week in week 10, the vulnerable populations is due. You have an exam. It's just going to get busy. So if you have some time this week, I would highly suggest not yet, Laura, not till 1. Right? I mean, not till 3. Laura? Anyway, Laura, I know we have to meet, but I have to jump off Zoom so this can record and then I have to start another one. Okay? Anyway, so where was I? It's going to get super busy after this week. Okay, so if you have some time, get that HESI prep updated or get it finished. I've already had a couple of people turn it in. I don't think from this section, but I've already had a couple of people turn in the HESI prep. I've had a couple of people turn in the vulnerable populations assignment. I will accept those assignments early, but this is a good week to get caught up with those big assignments. Otherwise, starting next week, it's going to get very. Laura, hang on a second. Hang on. Let me finish class. Okay. It's going to get very, very busy. All right. So use this week to catch up. And if you see something on the HESI prep, Danya will talk about that. Danya will talk about that Thursday. Okay. If you see something on the HESI prep that said, oh, I haven't heard about that. She hasn't covered that. The concept has been covered. Okay. It was just too med-surg focused for me to cover it in a community class. And that's why I have to go back to your 3 books. Make sense? Okay. And remember, what you put into that study guide, you'll get out of it because that is officially going to be your study guide for HESI. All right. That's what I use when I do my HESI prep in week 10, my HESI review, I do it from that assignment. It's as specific as we can get. Those are topics that are asked about. Okay. All right. So Laura, stay on. Danya, I answered your question. I apologize for being 8 minutes late. And you guys are free to go. If you checked your chat, I left some messages in there for certain people.